Good morning. Welcome to ILBS, and thanks Meenu, Ashish and the team to having such dignitaries around. It's a very relevant topic. I want to give you two insights, my personal insights into this. In early 80s, I had the pleasure of working and interacting with Girish Vyas. I don't know how many of you know Dr. Girish Vyas. He was the champion of blood transfusion in the US, and he was the one who discovered occult hepatitis B. He spearheaded the transfusion safety in the US as amongst the most decorated Indian in transfusion medicine. What Dr. Vyas did, he found out people who had anti-HBs, anti-core. In fact, he would have got with Blumgard the Nobel, HBs, anti-HBs, anti-core, and no DNA, no HBsAg. Liver biopsies were done and DNA found. And the term came tissue DNA. New England Journal 1965. He trained a galaxy of hepatologists. He was not a hepatologist. Amongst them was Hubert Bloom. Hubert Bloom, amongst the best known hepatitis B men. What I am trying to say, a very vigilant transfusion medicine person can make a sea of difference. The second person was Mizokami. Mizokami was is a hepatologist. Mizokami traced the origin of hepatitis C from every single country. He described genotypes. Now, I'm not sure, but till last year he was head of the Japanese Red Cross. And amongst the best scientists, what he was able to do, ये donor तो यहाँ से आया है, ये हेपेटाइटिस सी बैंकॉक से आया है, ये काठमांडू से आया है. He could trace every single and found from where did hepatitis C came. And I was working with him to find out how hepatitis B from mummies to the current hepatitis B. You know, hepatitis B was found in mummies. So this is a very old virus. What were the techniques used for this? What type of tissues? It would be amazing. This is a PNAS and then subsequently Nature paper, both by Mizokami. How they discovered Hep B in the mummies. The third part is, when I was deeply involved, and I am still deeply involved, is a national survey on blood banks. We conducted about 1100 blood bank survey. Many did not like it, but with hematologists, with the transfusion people, we found out, although 92 Hep C we were able to do in Delhi, but blood banks were not doing. So we conducted a survey of about 1100 blood banks. This was published in 2001 or so. To our utter dismay, only about 5% blood banks were doing Hep C. Very few were doing a good quality ELISA. This became and we wrote this book as Transfusion Associated Hepatitis. The fourth thing suddenly comes to my mind. Also I want to share, because we have such senior people. We had a very large number of people who were getting transfusion because of hepatitis in GB Pant, where I was working. The blood was negative for HBsAg, but after some time we found the patients were positive. So we dug out all the donors 181 or 182 donors, and HbA1c is negative. We use multiple HbA1c testing to find out the necessity of multiplex HbA1c, polyclonal rather than monoclonal Hep B testing. 3 out of 181 actually transmitted but were missed as HbA1c negative. This was one of the Voxeng paper which stimulated the NAT testing in country and overall. There is a huge need of transfusion medicine and maybe people like us, hepatology or gastroenterology, to work together. At ILBS, maybe we are the largest users of cryos and components. Am I right, Meenu? We may be the largest users. Every patient will need 4, 6, 8 units, and we never know the quality. And sometimes we are worried about the quality of cryo and the quality of blood products. Plasma, because we do in a given day, Amita will tell, better 4 to 6 plasma exchanges every day for our acute liver failure or acute on chronic or cholestatic liver disease. So, with the program that I see and the galaxy of experts that I see here, and I hear that we should have more of such CMEs, I totally endorse. I think we should meet, learn from each other, from your experience, from experience of all others. The detection should be such foolproof that there is no transmission, zero transmission. And I think the transfusion medicine people should follow, at least the residents, every single patient. They should see to it that nobody gets an infection. Acute liver failure, 50% of the ALFs are indeterminate infections. We do not know whether they are transmitted by HSV or something else by blood. So we think we have reached the best, but I think every day is the beginning of the best. We have to work more to provide an absolutely safe blood, and also there must be every year, you all set the standards, the bar should be raised, new diagnostics should come up which are easy and affordable. When you go to a hotel, you say, yeah, 3-star hai, 4-star hai, 5-star hai. नहीं, 5-star में ही रहेंगे, वहीं खाना खाएंगे. Can we not ensure everybody who gets blood that तुम्हें 5-star blood मिलेगा? और अगर 7-star है तो 7-star मिलेगा. There is no more need of any more testing. So let's strive to get the best possible blood for our patients. We as clinicians should be very vigilant to report to you that yes, there is a need. 2 more requests. Every blood bank should help incidentally found hepatitis B or C positive subject to go to a clinician, whoever. Although these are rules, but nobody follows. There was a policy in Australia called recall policy 1999. They recalled nationally every single hepatitis C positive donor and tried to interact and kind of monitor. We haven't such policy. I have been trying. So what we can do is anybody who has been tested positive must be advised to go and see. Hep B is a mother baby. Hep C is parenteral. Both of these are preventable. We are having World Hepatitis Day on 28th. I do like every blood bank to display a poster. Our blood is free of B, C and other infections. If you all can help, you can convey the message of a safe blood on 28th of July. And of course, we would like to have better testing and faster testing, universal NAT with every single virus added onto that in the cheapest possible way for us. Thank you all for being at ILBS and welcome and a very good luck for your CME. Thank you. And if you want to join National Academy of Medical Sciences, there are very few people from transfusion medicine in NAMS. If any one of you would like to hold a CME on transfusion, I, representing NAMS, would be very happy for a national CME or a regional CME or topic specific CME. But do become members and fellows of NAMS. Thank you.